All right, I'll hand it over to you, Dr. Gilbert.
Great, thanks. So thanks for having me back. It's a pleasure to speak to everyone again. So today's topic is going to be neoadjuvant and adjuvant or perioperative, both chemotherapy and immunotherapy. So this started as a chemotherapy talk that, and I've been giving this for over a decade, dating back to probably my fellowship days. And with more recent clinical trials coming online, we've added immunotherapy. So we're going to go through the rationale for systemic therapy prior to cystectomy. We'll talk about the randomized controlled trials that support adjuvant chemotherapy, and then talk about the neoadjuvant chemotherapy trials in a little bit more detail. There's more of them, and they're a little bit more robust in terms of design. And then we'll have a little bit of these few slides that touch on non-standard of care, non-guideline pathway treatment options or management options. So the first will be the natural history of complete responders. So patients who come in with a great response to chemotherapy and refuse local therapy with cystectomy or consolidated radiation therapy. And we'll get into the more modern cutting edge area of this topic, which will touch on molecular classifications of different subtypes of bladder cancer based on their genetic makeup, neoadjuvant and adjuvant immunotherapy trials, which is kind of related to molecular subtyping to a degree. And then another one of these call out subtopics that may have some clinical relevance, but is not really part of the guidelines. And we'll close with just some discussion on what clinical trials are currently ongoing for muscle invasive non-metastatic bladder cancer patients who are being challenged with combination regimens or novel agents that are being tested in randomized trials. Okay, so the rationale is for treating patients prior to cystectomy with perioperative neoadjuvant chemotherapy is in a large segment and a large percentage of patients, you can consider muscle invasive T2 non-metastatic bladder cancer as a systemic disease. So there's a high risk of occult micrometastatic disease at time of cystectomy. And these are two seminal trials that were published in the early 2000s. The first one out of USC by Stein's group, where over 1,000 patients were treated predominantly with cystectomy alone. Some of these patients did receive adjuvant chemotherapy, but very low use of neoadjuvant chemotherapy at University of Southern California during this era. And you can see that the survival out past 10 years for cystectomy really depended on whether patients had an organ confined tumor or whether they had disease outside of the bladder. So extravesical disease or lymph node positive disease was found in approximately half of patients, even though radiographic staging evaluation suggested that they were stage 2 or T2 disease. And you can see the concurrent recurrence-free survival percentages, both in the Stein cohort and in the European cohort published by Madersbacher. So for node negative, less than or equal to T2 disease pathologically at the time of cystectomy, you had 85, so between 73 and 85% recurrence-free survival. However, that percentage dropped precipitously once the tumor was outside of the bladder. So this would be pathologic T3 or T4 N0, or if nodes were positive, down to only about a third of patients without recurrence at 5 years. And the overall survival statistics mirror that trend. So very poor overall survival for patients treated with surgery, predominantly surgery alone, if nodes are positive, or if about a 50% flip of a coin survival probability at 5 years if the tumor is outside of the muscle layer of the bladder, even in the setting of negative nodes on lymph node dissection. So, and that kind of calls out that for at least 50% of cystectomy patients that you think are stage 2 and bringing to cystectomy, that it's probably there's a high probability of micrometastatic disease, and it could be considered a systemic disease in that subset of patients, or should be considered a systemic disease. So NCCN guidelines, the AUA and SUO guidelines, as well as the European Association for Urology guidelines, are all consistent with recommendations for consideration of neoadjuvant chemotherapy because of the randomized control trials that we'll be reviewing in the next few slides. The keys to take home are that these are multi-agent regimens. They must contain cisplatin to show benefit. And there's a 8% 5-year overall survival advantage proven through high level evidence in randomized control trials compared to a standard of just surgery alone. So there are some timing factors that suggest or theoretically underpin why chemotherapy given prior to surgery may be more beneficial or effective than giving it after surgery. So prior to giving chemotherapy prior to surgery can treat occult micrometastatic sites of disease prior to the local the administration of local treatment such as surgery. And the chemotherapy after surgery is providing chemotherapy after surgery prevents you or prevents a subset of patients who may not benefit or need chemotherapy, the exposure to the chemotherapy in the first place, and reserves it for those patients with aggressive histologies and at high risk of failure. So that in the setting of giving adjuvant chemotherapy or delayed for cause systemic therapy at time of recurrence, the goal there is to try to limit exposure to systemic therapy for patients who wouldn't need it or wouldn't benefit from it. The tolerance and compliance and completion rates of giving it before or after surgery vary, and there's also some theoretical benefits to giving it before surgery in terms of having lymph channels and vascular access to the tumor sites that aren't disturbed or altered by the surgery itself, as well as the potential ability for patients to better tolerate chemotherapy prior to surgery when their immune system and their physical function is more robust than trying to give it to them within 3 to 4 months after surgery while they're recovering from a major surgical event. So mechanisms of action for how these agents work. These are the most common agents used for both the neoadjuvant and adjuvant setting. So cisplatin is an alkylating agent. It interferes with DNA replication. Its main toxicities, and I think this is the main benefit for this surgery from a clinical standpoint, the major toxicities seen with cisplatin are nephrotoxicity, so decreased renal function, neuropathy, and myelosuppression. Methotrexate can cause myelosuppression and mucositis. Adriamycin, it can be can cause cardiomyopathy or be cardiotoxic, as well as myelosuppressive. And so these patients undergo, you'll see medical oncologists performing cardiac evaluations and getting echocardiograms prior to determining whether a patient can tolerate and receive adriamycin. Vinblastine is shortness of breath and myelosuppression, and gemcitabine is myelosuppression. So fatigue, altered white and red blood cell counts are the common toxicities across these different agents. The particular ones to really be cognizant of are cisplatin in terms of its neuropathy and adriamycin in terms of its cardiomyopathy. And in fact, in the case of cisplatin, the neuropathy can manifest in patients with hearing loss, with exacerbated hearing loss. So you'll oftentimes see medical oncologists being a little bit hesitant or reticent to give patients with a component of neuropathic hearing loss cisplatin. So the adjuvant trials that have been published to date, there are about 4 or 5 of them. have shown a decrease probability of progression and recurrence. However, most of these studies are notable for small cohorts and a lack of overall survival outcome. So they've been focused on more proximal recurrence-free and progression-free survival outcomes, not overall survival. And they've been hampered by relatively small patient numbers in the studies. And for that reason, none of these studies alone was considered, I don't think, practice changing. But in aggregate and in a meta-analysis that we'll look at, when you combine all of the data, you do see some survival benefit or signal of benefit. So the first one was reported by Skinner, again, out of the USC group in California, and they reported a decrease in disease relapse given chemotherapy compared to no chemotherapy, and that was all the way back in 1991. And then subsequent studies by Stockel and Frieda reported that adjuvant chemotherapy improved disease-free survival and cure fraction in high-risk settings, and those would include patients with obvious extension under the microscope of disease into the fat layer, so T3B, T4, or node-positive disease. And these are just some data from the Frieda trial. So you can see in the Kaplan-Meier plots that patients on observation after cystectomy had a much lower chance of freedom from disease progression compared to patients who were treated with adjuvant chemotherapy. But at between 2 and 3 years, you still see that the disease progression rate is about 50%, even in patients among the patients who received adjuvant chemotherapy. So this just calls out, I think, still a lot of room for improvement for those patients who are, despite receiving paired combination treatment with surgery followed by chemotherapy, still at quite high risk for recurrence. And in this study, overall survival was also examined, but did not show statistically significant difference. You see some slight separation in curves, but again, small patient numbers, only 25 patients in each group, prevented this separation from being statistically significant. When you put all of the data together, as I alluded to earlier, you do see a statistically significant difference in adjuvant chemotherapy patients in the red line here on the Kaplan-Meier curve compared to those control groups treated with cystectomy alone in the blue dotted line. And on the waterfall plot here, you can see, again, the pooled aggregate estimate for survival favoring adjuvant chemotherapy compared to surgery alone. There is one study published by Sternberg in Lancet Oncology in 2015 that looked at the question of giving adjuvant chemotherapy for high-risk features on cystectomy pathology specimen versus delaying chemotherapy and administering at time of recurrence. And so this was a phase 3 randomized control trial, which looked at immediate versus deferred cisplatin-based chemotherapy for T3 and T4 disease with or without positive lymph nodes. And 284 patients were randomized, so a pretty sizable study group. And they showed improved 5-year progression-free survival amongst patients given immediate adjuvant therapy versus deferred chemotherapy. And the difference was 48% 5-year progression-free survival, which is kind of in line with what we saw reported by the Frieda study and other adjuvant trials, versus 32% if you defer and delay chemotherapy administration. However, there was no statistically significant difference in overall survival, although I think a lot of people would argue that is probably numbers-based in terms of sample size, because it is a 10 percentage point difference of 57% higher than, 10% higher, 57% versus 47% for the patients treated with immediate adjuvant chemotherapy versus deferred chemotherapy. And that translated in an adjusted hazard ratio of about a 22% survival advantage for immediate adjuvant chemotherapy compared to deferred chemotherapy. So we talked about these concepts a little bit earlier on. There are some potential advantages to giving chemotherapy prior to surgery rather than after surgery. And so the potential advantages include an immediate treatment of clinically or radiographically occult metastatic disease. So not waiting for proving that the patient has disease in the lymph nodes on pathology and treating it at a sooner time. Effective delivery of the chemotherapeutic drug to the tumor sites because the blood vessels and lymph channels have not been disrupted by the surgery itself. Lower toxicity and better patient tolerability prior to surgery compared to after surgery, and then an ability to assess tumor response. So to watch lymph nodes shrink or to watch the primary tumor in the bladder shrink. And you see this not infrequently. Patients with borderline lymph nodes that are approximately 1 to 1.5 centimeters resolve after chemotherapy, or tumors that appear to be T3 or T4 lesions being downstaged to a potentially more surgically consolidatable tumor burden within the bladder. The potential disadvantages are a time delay to definitive local therapy. When patients come into my clinic and kind of talk about that or have concerns about that, I try to allay those concerns by telling them that chemotherapy, your start time of therapy starts when you start getting your chemotherapy, that surgery is not the start date, that the chemotherapy is the start date. However, there are two scenarios where the chemotherapy is either unnecessary. So in quote unquote low risk muscle invasive tumors that may not require it and have a same risk of recurrence and overall survival probability, regardless of whether they receive neoadjuvant chemotherapy or not. So those may be non-beneficial groups, or patients whose tumor does not respond to the chemotherapy. And in that case, you are potentially delaying definitive treatment with surgery. And there's a long history of neoadjuvant chemotherapy trials dating back to the 80s. They started as single agent trials, usually single institutional and usually smaller numbers, but you can see combination trials, particularly the MRC ERTC trial performed in the late 90s into the mid 90s, looking at neoadjuvant CMV, followed by either consolidative radiation therapy or cystectomy, was almost 1,000 patient study. And then also the SWOG study, which is also another hallmark study, SWOG 8710, which was one of the results of that study was one of the key factors in the United States for moving neoadjuvant chemotherapy to standard of care, at least in the guidelines. That was over a 300 patient study. And this is the MRC ERCT summary slide for the trial. It was a multinational randomized control trial looking at CMV for patients with T2 to T4A. It was designed to detect a 10% survival advantage. And patients were either randomized to neoadjuvant CMV, followed by consolidative therapy with radiation or surgery, or just primary radiation or surgery with no neoadjuvant chemotherapy. You can see that most patients got all of their therapy. Of the almost 500, most patients got all 3 cycles of their therapy, but there were some patients that could only tolerate 2 cycles or 1 cycle, and 28 patients that didn't receive any at all. Nevertheless, an intention to treat analysis, you see a clear survival advantage of about 5 to 8% for 7% at 8 years for the neoadjuvant group compared to the surgery to the surgery alone group. And that translated to a statistically significant hazard ratio of 0.85. So a 15% survival advantage in hazard ratio, and a 15% reduction in risk of death. In terms of hazard ratio, when talking about neoadjuvant CMV versus consolidative therapy alone. When you break it down in terms of whether patients got radiation therapy or surgery, you saw a bigger benefit in surgery patients compared to the radiation therapy patients. So this is the surgery cohort, and you can see that the difference in the survival advantages amplified to a degree for patients who received consolidation with surgery compared to those receiving consolidation with radiation therapy. So SWOG 8710 is the other hallmark neoadjuvant chemotherapy trial that I want to discuss, and that was performed in the United States across multiple institutions through the Southwest Oncology Group network. And about 154 patients were randomized to cystectomy alone versus 153 patients who received 3 cycles of MVAC chemotherapy, so 4-drug regimen with significant toxicities and adverse events that potentially limited completion of all 3 cycles for some patients. And they looked at patients stratified both by age and stage, and the study was designed to detect a 50% difference in median survival between these 2 treatment arms. And they also wanted to look at downstaging and its survival advantage. So this is one of 2 kind of take-home slides for that study, and you can see that the MVAC arm, which is in the Kaplan-Meier curve, is represented in the upper arm, is separate and higher than the cystectomy alone arm. So this was a disease-specific survival endpoint, hazard ratio of 1.66. benefiting chemotherapy. So that's kind of like a flipped hazard ratio, because we're used to seeing them below 1. The way they calculate this hazard ratio is there's a 66% benefit to giving chemotherapy compared to doing surgery alone. But I think this is the slide that I kind of revisit with patients when I'm counseling them towards neoadjuvant chemotherapy in the clinic, and that's complete response rate. So in the upper 2 curves, this is patients who ended up with a P0 response, so no tumor noted on final pathology after cystectomy, regardless of whether they received chemotherapy or just had a P0 on after their TUR resection and then going on to cystectomy, versus those who had residual disease in the bladder on final pathology. And this translates, so a complete response or P0 response at the time of cystectomy translates to approximately an 85% survival at 5 years. So that's kind of a statistic that I share with almost all my patients when we're talking about neoadjuvant chemotherapy and cystectomy. When you look at complete response rates across the MRC ERCT trial versus the SWOG trial, they're pretty similar. So in the control arm, and this is basically TUR alone, complete response rates is about 12%. In the experimental arm or the treatment arm, it's about 3 times that. So 33% in the MRC ERCT trial, and 38% of patients had a complete response rate in the SWOG trial. Patients will, and we'll talk about this, I think, in the next few slides, patients will sometimes come in after surgery and say, well, you didn't find cancer in my final specimen. Did I need to have my bladder removed? And the answer to that is no, you're at high risk for tumor recurrence. And if we're treating the disease comprehensively and for long-term benefit, then the treatment plan is combined chemotherapy plus surgery. So the surgery is an obligate recommendation, although there are patients who are not fit for cystectomy or flat out refuse it. And we'll get into what kind of risk probabilities they have for recurrent disease in just the next few slides. A meta-analysis has been done across all the randomized control trials looking at multi-agent neoadjuvant chemotherapy. And what you can see here is, again, across the force plot as well as the Kaplan-Meier curve shows a separation in curve with a benefit for the neoadjuvant treated patients compared to surgery or consolidative therapy alone. And this is about a 5% overall survival advantage. 5-year survival for neoadjuvant chemotherapy patients across all stages. So this is a blended outcome is about 50%, and it's 5% lower for a control group. There are folks who don't, by folks I mean surgeons, who don't think that 5% survival advantage is high enough to warrant giving chemotherapy to everyone. And so in the United States, there are certain centers and certain surgeons that are known to be low utilizers of neoadjuvant chemotherapy. Everywhere I've been through training, residency, fellowship, and a few places that I've been as a staff faculty surgeon, we've always been high utilizers of neoadjuvant chemotherapy. A counter argument to the 5% is too low kind of stance is that, you know, this is a materially higher survival advantage. There's a high proportion of patients after surgery who just never recover and are able to get adjuvant chemotherapy. So you can't rely on the fallback of adjuvant chemotherapy in everyone. And a 5% survival advantage in breast cancer is widely accepted as a high and worthy threshold to treat women aggressively with chemotherapy or targeted agents compared to local treatment for breast cancer alone. So it really depends on stance, though, and we've seen over the course of 20 years, when you look at prescribing and administration data, we've seen a slow uptick of neoadjuvant chemotherapy use across the country in the United States to about 55%. Okay, so the reason there was a shift away from MVAC to a 2-drug regimen, cisplatin and gemcitabine, and this shift was made without any of the randomized control trials in the neoadjuvant setting examining this 2-drug regimen compared to surgery alone. All of the other trials were CMV or MVAC or some other regimen. However, in metastatic disease, there was a non-inferiority trial, the Vondermas trial published in 2000, that showed no significant difference in non-inferiority of gemcitabine and cisplatin compared to MVAC for metastatic disease. And the 2-drug regimen is more tolerable with fewer adverse events than the 4-drug regimen. So what happened in prescribing patterns for bladder cancer is gemcitabine and cisplatin kept on being used, but you saw a jump in the use of gemcitabine, ostensibly connected to or co-prescribed with cisplatin, and you saw methotrexate and vinblastine, which are components of MVAC, decline precipitously around 1999-2000. But that's changed again, and that's because of 2 small pilot studies published in 2014 showing that administration of a dose-dense or accelerated form of MVAC with bone marrow support was a way to make the drug regimen more tolerable. And so these small studies of around 40 patients showed that with giving an accelerated or dose-dense prescription of MVAC, you could get 3 or 4 cycles in, and you could have high rates of P0 or complete pathologic response at cystectomy, and that grade 3 and 4 toxicities were low, 10% in the Churi study and 0% in the PILMAX study. You also accelerated the time to surgery. So instead of a 3 to 4 month time window from starting chemotherapy to time of surgery. Chemotherapy was done in about 8 or 9 weeks. So patients were ready for surgery usually within 3 months, rather than coming to surgery a month later with a 2-drug regimen, gemcitabine and cisplatin. We've looked at this at Moffitt Cancer Center, and this was published by one of our fellows, Chas Payton, and published in JAMA Oncology back in 2018. And what we saw was a high rate of downstaging. So if you look across all the neoadjuvant chemotherapy regimens given during a 10 or 15-year time frame at Moffitt Cancer Center, you saw about a 40% chance of any downstaging with gemcitabine and cisplatin, and about a 25% complete response rate. In the dose-dense MVAC group, you saw more like a 50% any downstaging probability, and over a 40% complete downstaging regimen. This is compared to 2 other scenarios. One is no chemotherapy at all, where you saw much lower rates of complete or partial downstaging, or in settings with in patients receiving gemcitabine and carboplatin, where those basically mirrored the probabilities of not getting chemotherapy at all in terms of downstaging. And this is one of the take-homes from this study, is that carboplatin is often substituted for cisplatin in patients who are cisplatin ineligible, or who begin on cisplatin and then develop toxicities that prevent completion of the cisplatin component of the regimen. And those would be primarily renal impairments with declining renal function, or development of neuropathy, or significant myelosuppression. However, when we looked at adjusted models for survival advantage or downstaging probability, carboplatin, this regimen, gemcitabine and carboplatin, was no better than no chemotherapy at all. And so this is, I believe, a caveat call out in some of the guidelines, where if patients cannot get cisplatin, they should be treated with a primary surgery or on a clinical trial, but carboplatin should not be used. So these are some of the Kaplan-Meier curves from our study, and you can see very high survival probability with the dose-dense MVAC compared to the gemcitabine, and gem carboplatin is all the way down here in the basement. And we also validated the idea of complete response. So patients who benefit most are the ones whose tumors respond and have no residual tumor in the bladder, greater than about 80%, greater than 75% survival in that setting, versus residual disease. And this is primarily driven by chemorefractory tumors that are outside of the bladder or in the deep tissues of the bladder, and limited therapeutic options, so high risk of patients progressing and succumbing from their bladder cancer. You also can see that patients were ready for surgery, or they got to the OR faster with the dose-dense MVAC regimen compared to the other regimens that we examined. There are 2 recently completed neoadjuvant chemotherapy trials that tried to compare gemcitabine versus dose-dense MVAC. One is the Coxon study, which was a SWOG trial looking at 4 cycles of gem-cis versus 4 cycles of dose-dense MVAC. They were looking at exploratory genotypic tumor expressions as markers for phenotypic chemoresponsiveness. 237 patients randomized, about 167 analyzed, and their preliminary results were primarily pathologic response rates, which were a P0 rate of dose-dense MVAC of 32% for gemcitabine and cisplatin, and 35% for, dose-dense MVAC was 32% and 35% for gemcitabine and cisplatin. And not surprisingly, based on those downstaging percentages, the Coxon score, which was the algorithm that they used to determine whether patients would be more responsive to cisplatin, gemcitabine versus dose-dense MVAC, was not prognostic. And then the VESPER study, which was a French study, phase 3 trial of 4 cycles of gemcitabine versus 6 cycles of high-dose MVAC chemotherapy, looking at 500 patients in a 3-year disease-specific survival outcome, showed 10% improvement. The designs to show a 10% improvement in the high-dose MVAC arm. I'll show those results in a minute. So the Coxon trial we already talked about. The Coxon GEM score was not significantly predictive for response of individual chemotherapy regimens. So this is a sign that this paradigm of this Cox score will not move forward and isn't able to reliably differentiate patients or tumors that would be better treated with gemcitabine and cisplatin versus dose-dense MVAC. In the Vesper trial, so 28 French institutions randomizing those 500 patients, 88% of the cohort received neoadjuvant chemotherapy. 60% of the patients who were planned dose-dense MVAC or high-dose MVAC received it versus 84% of the patients who received gemcitabine and cisplatin. So this is evidence that despite the dose-dense nature of the MVAC regimen and supportive medicines to support marrow function, is still fewer patients tolerated it than the 2-drug regimen. All cohort 3-year progression-free survival was 64% for MVAC versus 56% for cisplatin, and this favored MVAC. And the 3-year neoadjuvant progression-free survival for neoadjuvant chemotherapy was 66% versus 56% for patients who didn't receive chemotherapy. So we alluded to this earlier in the discussion. What happens when a patient has chemotherapy? They come back in and they have complete radiographic and maybe endoscopic complete response and no residual tumor within the bladder. The bladder looks pristine and there are no enlarged lymph nodes or sites of disease outside of the bladder. And the patient says, I don't want my bladder removed. There are several small series that have looked at recurrence and survival outcomes among that group of patients who appear to have had a clinical complete response after neoadjuvant chemotherapy and then deferred or declined surgery. The MSK cohort published by Harry Herr, which was one of the first reports on this topic, was about 30 patients, and they had a 10-year overall survival of 75%, which is not bad, and about a 58% of that group of patients survived with an intact bladder, meaning they didn't require a deferred cystectomy or delayed cystectomy. There were about 7% of patients who, when they recurred, their tumor had metastasized already and they were no longer salvageable. The Sternberg cohort is a larger cohort, about 100 patients. So of 100 patients treated with neoadjuvant chemotherapy, about 37% had a complete response. This was MVAC chemotherapy, and they were followed without cystectomy. Again, derived or driven by patient preference. 10-year survival of about 68%. About half of those patients managed in this fashion survived with an intact bladder, and about 5% developed invasive recurrent disease. So a combined Columbia University and Memorial Sloan Kettering cohort published by Maza more recently involved almost 150 patients treated with neoadjuvant chemotherapy alone between 2001 and 2017 with a almost 5-year follow-up. 5-year disease-specific survival was 90%, overall survival was 86%, cancer-free survival 76%, and recurrence-free survival of 64%. These are fairly favorable survival percentages. About half of patients had a recurrence, but most of those recurrences were non-muscle invasive bladder cancer and salvageable with resection and intravesical therapy. About 11% of patients had a muscle invasive recurrence. 3 patients with muscle invasive bladder cancer and 1 patient with non-muscle invasive bladder cancer did succumb to their bladder cancer because of a metastatic, ultimate metastatic recurrence. And then there's a further update of the HER cohort with a 10-year median follow-up in patients treated with bladder sparing surgery. So these are neoadjuvant chemotherapy patients treated with either a TUR resection or a partial cystectomy. And almost 200 patients were followed in this way. 100 patients opted for TUR observation, 63% partial cystectomy, and 31% were treated with a post-neoadjuvant chemotherapy cystectomy at time of recurrence. Their overall and cost-specific survival didn't difference whether the patients underwent a deferred cystectomy or bladder-sparing surgery. 10-year overall survival of 77% in the cystectomy group versus 87%, versus 72% in the bladder-sparing group, and 10-year disease-specific survival of 87% after cystectomy versus 92% after bladder-sparing surgery. There were 4 deaths in the cystectomy group and 13 deaths in the bladder-sparing group. 55 patients, or 34% of the bladder-sparing patients, did have a recurrence. 4% of those had lethal recurrences and died of unsalvageable disease. And a high percentage of patients treated with bladder-sparing surgery had intact functional bladder. So not standard of care, but this is not an uncommon scenario when you think about 25 to 40% complete response rates after neoadjuvant chemotherapy in a group of patients who are older and have a preference for bladder sparing. This is a clinical topic that comes up in my clinic not infrequently, and these are the numbers that I use. I generally tell them that there's about a 40 to 50% chance of having a tumor come back, about a 10 to 15% chance of having a muscle invasive tumor come back, and between a 5 and 10% chance of a lethal tumor coming back that can't be salvaged. And patients have to do their own calculus and risk assessment to decide whether they want to proceed with the surgery or hold back and be followed with close observation. Okay, so now we're going to get into immuno-oncology and checkpoint inhibition. So bladder cancer cells are highly expressive of PD-L1, suggesting a tumor-associated immune tolerance and escape from the immune system. 20 and 30% expression at the 5 and 1% cut point thresholds for testing of those immune markers. And urothelial carcinoma has a high mutation burden. It's third highest after melanoma, and I think lung are the other two. And that increases its likelihood that it's an immune mediated. There's immune mediation and recognition of tumor, and this should be familiar to most urologists, given that immunotherapy with BCG treatments is such a mainstay for our treatment of non-muscle invasive bladder cancer. So checkpoint inhibitors work by targeting the PD-L1 or PD-1 marker, which the tumor cells use to avoid immune surveillance. So checkpoint inhibitors block that receptor interaction that in turn is blocking the T cells, and that enables T cell mediated immune anti-tumor response. So the immune system, basically a cancer cell through these markers is able to kind of cloak itself and be invisible to the immune system, and the T cells can't, the T cells are kind of not able to survey or recognize cancer cells as foreign, and the checkpoint inhibitors block that receptor, block that receptor interaction, that cloaking, and expose the cancer cells for immune recognition and T cell action. So in metastatic cancer, Keynote 045 was a randomized phase 3 trial of pembrolizumab versus second-line chemotherapy of docetaxel, paclitaxel, or vinflurine in 270 patients randomized to the checkpoint inhibitor versus 272 patients to second-line chemotherapy. And they found that there was the overall survival was significantly increased in the pembrolizumab group by about 3 months, and that there were fewer treatment-related adverse events, particularly of high-grade events, in the checkpoint inhibition group compared to the chemotherapy group. So these are swimmer plots and Kaplan-Meier curves showing the survival benefit and response profiles of the pembrolizumab versus the second-line chemotherapy. So this was moved to neoadjuvant chemotherapy in PURO-1 with pembrolizumab, published by Necki in Journal of Clinical Oncology in 2018. This is a phase 2 non-comparative trial of 50 patients, looking at single-arm efficacy defined as a P0 response, as well as some biomarker responses of 3 courses of neoadjuvant pembrolizumab versus cystectomy. 92% of these patients were cisplatin eligible. Most of the trials performed with neoadjuvant checkpoint inhibition are focusing on the cisplatin ineligible population right now, and that's about 50%. That's about 50% of our bladder cancer patients, predominantly driven by poor renal function. The most frequent adverse event was thyroid dysfunction, but patients also had pneumonitis or other inflammatory conditions. 42% of patients achieved a P0 downstaging at surgery. There were 20% of patients with node-positive disease, suggesting some kind of lack of response to checkpoint inhibition. They didn't really find any significant gene signals other than the PBRM1. There's a second study called the Abacus study, which is also a phase 2 efficacy and safety study of neoadjuvant atezolizumab for muscle-invasive bladder cancers, and this was a cisplatin ineligible cohort of patients. 74 patients were enrolled, and 59 most received 2 cycles. Only 15 received only 1 cycle. Of the 74, 67 went on to cystectomy, and about a 29% complete response rate, or not quite complete response rate. That's complete response rate P0, 16 of them, and then there were additional 4 patients that had CIS only. They did see higher response rates for patients who had positive PD-L1 testing, 40% compared to those who were PD-L1 negative. So their tumors didn't express or didn't highly express the PD-L1 marker. In terms of radiographic response, 28% of patients had a radiographic response and 17% had a radiographic progression, which again suggests that not all tumors are going to be suitable for checkpoint inhibition. About almost a fifth will not respond based on this data. Fatigue was the most common adverse event, and transaminitis was seen in about 5% of patients. So the final result the report out of the Abacus trial for 2-year disease-free survival and overall survival for 2 cycles of atezolizumab given for cisplatin ineligible patients prior to cystectomy showed that there was a partial clinical response in about 31% of patients. 2-year disease-free survival was 68%, and the 2-year overall survival was 77%. Okay, so there are a lot of trials. The study isn't, this slide is not to study in detail, but just to show that there are a lot of neoadjuvant, there's a lot of activity in the neoadjuvant space in terms of immuno-oncology and checkpoint inhibition, looking at single agents and combination therapeutic agents, as well as chemotherapy and checkpoint inhibitor combinations in the neoadjuvant setting. So those will be reported out in the next few years, I suspect. Okay, so adjuvant. So this study, we're running a little bit tight on time, so I'll keep going through this slide, and then I'll try to get through the next series of slides, but if people have to leave, please just let me know, and I can share slides at a later time. So the Checkmate 274 study, a randomized phase 3 trial looking at 353 patients, randomized to adjuvant nivolumab versus 356 patients treated with placebo after cystectomy, showed that there was a improvement in disease-free survival for high-risk muscle-invasive bladder cancer treated with cystectomy, followed by the checkpoint inhibitor, regardless of PD-L1 status, and highly tolerable as well. So standard, the implication for standards of care in the US, patients with high-risk features after cystectomy are now being referred for adjuvant nivolumab for at least a discussion with a medical oncologist, whether it's worth doing because of this study. And here's the Kaplan-Meier curve showing higher survival percentage or probability for the checkpoint inhibition versus that with followed with placebo. And this was, even though you saw it both in patients who had high expression of PD-L1 versus low expression of PD-L1, there was a gradient. So when there was greater than 1% expression of PD-L1, you saw an even greater benefit favoring the checkpoint inhibition compared to the total population. So the last topic we'll talk, the second to last topic we'll talk about is molecular classification of bladder cancers. And so there's a lot of movement in this field, and the underlying principle is to treat bladder tumors based on their genetic profile and try to match treatments to the genetic markers or pathways that underlie the tumor formation, compared to treating all tumors based on clinical stage alone. There are multiple different classification schemes, the Lund, Sealer, MD Anderson, the UNC, and the TGCA. And they come down to generally a luminal versus basal with a luminal infiltrated or a P53-like, and then there's a neuroendocrine version that we'll talk about it in a minute. But these may have therapeutic implications based on the genetic markers that are upregulated. Some of these tumors may be more sensitive to chemotherapy, such as the basal tumors tend to be more chemosensitive than the luminal tumors. And the luminal infiltrated tumors may be more sensitive to checkpoint inhibition than either luminal or basal tumors. The neuroendocrine group of tumors are very chemosensitive, but to a different regimen than what we've talked about thus far. I'm going to, oops. Okay. So the newest consolidated classification or unified consensus classification consists of 6 different subtypes: luminal papillary, luminal non-specified, luminal unstable, stomal rich, basal squamous, and neuroendocrine. And you can see the clinical as well as the molecular or genetic profiles of each of these groups. And the suggestion that, like, the neuroendocrine tumors, for example, are sensitive to cisplatin and etoposide chemotherapy regimens, while the luminal tumors may be less chemosensitive. And if you were to operate on a patient group without any neoadjuvant therapy, it'd probably be this luminal papillary group. The luminal non-specified and luminal unstable groups may be more chemo resistant or less chemosensitive and more immunosensitive. These are all kind of preliminary studies and outcomes. They've not yet been validated as a classification scheme that has therapeutic implication yet. And I suspect the next round of both metastatic and neoadjuvant clinical trials being done, regardless of agents, will use classification schemes to try to match patients' tumors to the right therapy. Okay, so the last topic is the role of surgical consolidation away from the bladder in patients who've been treated with neoadjuvant chemotherapy, but either came in with metastatic disease in the retroperitoneum or in the chest, and then had a partial or complete response, or patients who have persistent lymphadenopathy outside of the bladder after chemotherapy. How is there a role for surgery, basically? And so most of these studies are observational and single institutional, and the role of surgery is estimate the benefit of surgery in these patient groups who have metastatic disease or at one point at time had metastatic disease away from the bladder is limited. We think about to 10% or less of patients who would benefit from a aggressive surgical approach. In terms of pelvic lymph node metastasis, there is the fewer lymph nodes involved is associated with a lower risk of recurrence. So if we have patients who come in with pelvic lymph nodes and have a complete response, radiographically, we take them to surgery. If we find tumor in the lymph nodes that's micrometastatic at the time of surgery, we know that if they have very few nodes or small percentages of nodes involved, then they may have benefited from the surgery compared to if you had not performed the lymph node dissection in them. But in patients who have multiple lymph nodes or bulky lymph nodes at the time of surgery, the surgery is probably not helping them. RPL&D at the time of after chemotherapy, if you find positive disease in those lymph nodes, that's almost universal for recurrence and death from disease at some point. If the lymph nodes are clear, then even if they came in with positive lymph nodes prior to chemotherapy, then those patients do fairly well. I would say that RPL&D at the time of cystectomy after chemotherapy is prognostic mostly. There is limited literature on pulmonary resection or radiation therapy to partial response or complete response to pulmonary mets. And this is one area where if I did have a patient who had a oligometastatic disease with 1 or 2 sites in the lung, and they had a very good response to chemotherapy, but had persistent disease within the bladder, and they were young and fit, we would aggressively treat the bladder with cystectomy and treat the pulmonary metastasis with either targeted radiation therapy or a wedge resection via thoracic surgery. Okay. So in the interest of time, this is the retroperitoneal lymph node dissection data, both published by MSK and MD Anderson. And you can see in very small numbers of patients, about half of patients will have residual disease in the retroperitoneum and the lymph nodes. And of the ones who undergo RPL&D, a high percentage die within 2 years after surgery. But if disease is cleared out by the chemotherapy and the lymph nodes are negative, they have not unreasonable survival percentages, up to 50%, and similar numbers from MD Anderson. We've looked at this at Moffitt with about 15 patients, and the data is about the same in terms of survival percentages. So multiple different studies on the horizon in terms of how to treat complete responders after neoadjuvant chemotherapy. We won't have the final results of these studies for 2 to 5 years, I suspect, but there are studies that are trying to match patients to the correct chemotherapy regimen, and then if they have complete responses, avoiding surgery and looking at bladder preservation methods, and trying to limit the morbidity, the overall morbidity of treatment for this disease. So I know that was rushed and we're a little bit over the hour, but I have a few minutes to take questions, and I hope that was informative. I did a lot of medical oncology, not a lot of surgery there.
Go ahead, Dr. Solomon.
Thank you very much. Thank you, Dr. Scott, for your excellent flipping of the treatment of this muscle invasive bladder tumor, and to bring to us so that we have a lot of details from your discussion. So my question is it approved for non-urothelial tumors for bladder tumor, this neoadjuvant therapy? And the other question is immunotherapies and chemotherapy. Is it still FDA approved, or is it still on the process of approval for a patient?
So your second question first. All the neoadjuvant checkpoint and immunotherapy trials have been phase 2 non-comparative trials. So we don't have sufficient level of evidence for standard of care approval of neoadjuvant checkpoint inhibitors as a standard of care. So the medical, for patients who are cisplatin ineligible who come through our clinic, when we ask the medical oncologist to consider the checkpoint inhibitors, their first question is the patient metastatic, or there is a kind of loophole for indications, FDA approved indications called advanced advanced disease, non-surgically resectable. So you can get some of those patients to checkpoint inhibition, but true neoadjuvant chemotherapy followed by combined multimodal surgery or post neoadjuvant surgery is not approved in the US. And those phase 3 randomized control trials really need to be done before we get there. In terms of your second question, for non-urothelial, all of the clinical trials done for neoadjuvant chemotherapy were done in urothelial-based tumors. There were subsets of variant tumors, so micropapillary and plasmacytoid, squamous or adenodifferentiation. And our data and some of the clinical trial data suggest that for most of the variants, they still respond to neoadjuvant chemotherapy. So I don't view variant histology as a reason to go to surgery first, compared to send them to neoadjuvant chemotherapy. For non-urothelial tumors, which I think was the main part of your question, we don't give neoadjuvant we don't give any neoadjuvant chemotherapy for pure squamous cell carcinomas or pure adenocarcinomas. Those patients go to surgery straight away. For patients with neuroendocrine tumors or small cell tumors, those patients go to cisplatin and etoposide chemotherapy prior to surgery, universally, because the neuroendocrine tumors have a high risk of metastatic spread without systemic therapy, and they're chemosensitive to that regimen.
Well, Dr. Gilbert, I know that you're in a time crunch. I just wanted to take a moment to thank you for presenting again, and Dr. Solomon for helping organize.
Absolutely, my pleasure.
All right, if that's all of the questions, then I will send a link to this recorded lecture. And I hope everybody has a good rest of their day.
Okay.
Thank you very much.
All right, take care.